Okay, so our next speaker is Dr. Debdulal Chakraborty. Uh, Share your longest days. Dr. Debdulal Chakraborty is the head of the department retina service in our Shadow Police Center, Disha Hospital.
Thank you, Dr. Boral, and this is something that I share with him because we work in Disha hospitals, and we actually have OT days in common with Dr. Samar Basak, who happens to be the AIOS president, and he's also our cornea boss and one of our directors. So this is regarding SFIOL and corneal opacities. So these are much speeded up surgeries, no financial interest, of course. So this is the first one is SFIOL in moderate corneal opacity. So for any surgery, what is essential is the ability to see what you are doing. But if you cannot see what you are doing, then you are in real soup. And both of us have long days for these kind of surgeries. But at the end of the day, both of us are happy that we could maybe help chip in our bit. So this was a 61-year-old gentleman post cataract surgery elsewhere 1 year back. With a ACIOL and presented with corneal opacity and was slated for a 2-stage surgery, initially seen by Dr. Basak himself. Generally what he prescribes is that we do the first stage surgery with a IOL removal and SFIOL, and then he goes and does the EK, maybe DMAC or DSEC. So let's look at this. I have actually removed the epithelium to facilitate a little bit of make a little bit of clarity for me. So once the epithelium is removed, we mark and do the usual peritomies. And as you can see, these are really speeded up surgeries. This is a surgery that took me around 50 minutes as opposed to a normal SFIOL time of maybe 20-25 minutes. So you can see initially I'm looking into to find out if there's any gross thing that's visible inside in the posterior segment. So we open up and we try to manipulate the ACIOL. So this part is the easy part. Usually this is the easy part, as you will see slightly differently in the next case. And we are able to manipulate this ACIOL for once without any hyphema or anything, and we take it out. And in the process we break the haptic and we retrieve it. It's there in the wound only, and then we go in and do a little bit of anterior vitrectomy, and then I check whether there's any posterior segment pathology. Looks fairly good only, and then I enter for the make the entries for the forceps. And this is the trickiest part. If you notice here, this it has gone back. So the trickiest part is to actually hold the haptices of the we use Acrisoft multi-piece IOLs, and so that is the most tricky part to sort of do, because you cannot really see in this kind of corneal opacity. And this was one of the cases where there was lesser corneal opacity. As you can see, it's very difficult to grasp this and take it out. So thankfully after a lot of attempts at visualization, it came out, and then the other side also, the haptics came out, and what I generally do is I just tuck in the ends into a tunnel and leave the rest as it is, and then finish it off with glue. So this is kind of the end of the surgery, and happy for me. And the next part was actually the one that brought in the smile to the patient. The patient underwent DMAC by Dr. Basak, and had 6/9 partial vision after 1.5 months. So that was something also with a little bit of pupilloplasty that he did. So this was really awesome for the patient. Now the next one is a patient who was one-eyed, had lost another eye to an endophthalmitis, and again the same advice: vitrectomy with IOL removal with SFIOL, and the next stage would be a DMAC or maybe a DSEC. So this was the kind of corneal opacity that we started off with, and this is a surgery that actually took close to 1 hour 40 minutes. So even after removal of the epithelium, It's not really very nicely visible, but anyway, we went in, and as we went in, we saw that there was something on the cornea. There was this whole layer. So, we initially did a little bit of anterior vitrectomy, and then we tried to manipulate the ACIOL, and this was, something, this was stuck. So basically, what had happened was, this part, there was a PI that was done by the previous surgeon, and one of the haptices had gone inside through the PI. So we had great difficulty, lot of time we spent, and the cornea was folding up. This part actually was folding up, and we had to do repeated viscoelastic injections, and finally we got hold of one haptic, and we couldn't remove the IOL in toto. So what we did was we had to cut one of the haptices and remove whatever was available, and then we went in. We thought we could pull this out. You can see there's a PI there, and it had gone in through the PI, and even then we couldn't manipulate it. So finally I thought, okay, let's cut it off again, and we cut it into two pieces and brought one part out, and then using a bimanual technique, using a dialer and a McPherson's forceps, we finally could get it out. So this was really tiresome, and we were just hoping and praying that we could finish the surgery. And then I thought, okay, let me bring my 26 gauge cannula needle to get this out. The first one came out easily, and we thought that we will put in a same 26 gauge needle, bring it right up to this part, as you will see here, so that at least we don't have problem visualizing how to put in the haptic. This part went well, but maybe I was too hasty, and the needle came out but the haptic did not come out. So we were back to the usual handshake technique of sorts, and went in with 2 forceps, and this was again very tough. Probably spent around 15-20 minutes trying to figure out where the haptics was. Ultimately a bent haptic came out, and finally we straightened it up and inserted the two into the tunnels, and ended up the surgery. So this he has actually just done a DSEC for this patient, and patient has 624 partial vision. So this is also something that is great for the patient. So together we can make a difference. Thank you so much.
Thank you, Dr. Debdulal. Basically, what is your experience if you keep in retro illumination mode of the microscope, so that you're grasping the second optic or the first optic will be easier?
Sometimes I use, sometimes I do use the retro illumination. Sometimes I even use the chandelier.
Yes.
But like it is sometimes nothing works, and in very bad corneal opacities it's very difficult to sort of especially
you can use intracameral illuminator by the assistant, so that or through the pars plana, if your assistant is smart enough, he can just hold
that is what we use.
Little bit,
chandelier
so
sometimes.
Chandelier
that helps.
Or that routine illuminator in the anterior chamber.
Right.
Yeah.
Yes.
You can insert chandelier at the limbus itself.
Yes.
And do a PI in that area where cornea is clear, and you can do your manipulation in that area.
PI in the sense?
A good large surgical PI, peripheral iridectomy,
For?
to visualize things.
No, this is
the area where you don't have corneal opacity.
no. Usually these are like the PI is not an issue, because with
PI, what happens is when that gives you a window to visualize posterior segment and repair detachment. If you are operating,
I get your point, but really haven't had the necessity to do a PI, large PI, primarily because these patients will be undergoing a DSEC or a DMAC, so he will be putting in gas. So as much of the pupil, like the iris is spared, is good for the corneal surgeon.
Dr. Debdulal,
Yeah.
Since you share OT with Dr. Samak on the same day, the first case at least I think combined both could have been on the same day. I mean, it was not a,
I think I have very poor knowledge of cornea. I have poor,
not you.
Yeah,
you and
yeah.
Samak together
Yeah.
done on the same day rather than.
But that you cannot do a DMAC and a SFIOL on the same day. I think that would
I
be a
think
difficult
it was
proposition.
done once I had such a case. I mean, I don't do it, but the cornea guy who's handling the case, he's capable of doing a.
We've actually done PK with like, vitreoretinal surgeries, but PK as in like, you with a sort of,
One of a
normal
case, not
PK,
I don't do the
not EK.
Basically, Dr. Debdulal and myself, both of us are doing simultaneously on Dr. Boshak's case in all PBKs or ABKs cases. But the thing is, if you do it on the same day, basically you don't know what would be the stabilization of this IUL. If the IUL is stable enough for next
You're
2
worried
to
about
3 weeks.
stimulation on this first
No,
day.
okay, I know it is stable. SFIL is pretty much stable. If you injure the patient on table also, it will never dislocate. But if it is perfectly inside the intrascleral tunnel, fitted into the intrascleral tunnel, but still due to the further not to aggravate the inflammation or other things, because the preoperative counseling, it is very important, and preoperative making the importance of the understanding, like what is the situation, and you have to go for the 2-stage surgery will definitely give you the maximum result. That's
Because I had once a thing like this, vitrectomized eye, the scleral fixated and this corneal decompensation. The
Yes.
cornea guy who's handling is also capable of doing a scleral fixated, so he did it himself, both.
Right.
So
But you cannot do the vitreous base section, PVD induction, cornea guys.
He doesn't like it.
Okay.
He doesn't like it. So you have to listen to the president.